Sometimes the most life-threatening diseases may begin with the mildest symptom or subtlest discomfort. When you are unaware of what to look out for and when to seek immediate medical attention, it can lead to worsening of the disease and cause severe consequences. That is why we at Apollo Hospitals have been regularly hosting these FB Live sessions to give you factual information straight from our top medical experts. We present the authentic details so that you don't get confused and misled by the plethora of social media myths and misinformation all around you. All through this month, we're going to discuss a disease where every minute counts, and the longer it goes untreated, the greater the potential for damage and disability. Yes, I'm talking about stroke, the condition where the blood supply to a part of your brain is interrupted or reduced, preventing brain tissue from getting the required oxygen and nutrients and causing very rapid death of brain cells. One of the types of stroke is ischemic stroke, and today we are going to discuss, as part of our stroke awareness series, all about acute ischemic stroke, why it happens, and what are the treatment modalities, what are the recent treatments, what is the recent evidence-based protocols that we are using to treat ischemic stroke, and so on. To discuss this topic with us, I'm delighted to welcome Dr. Rajesh S. Reddy. Dr. Rajesh Reddy is one of the most eminent neurosurgeons in Hyderabad. He is Senior Consultant Neurologist at the Apollo Health City, Jubilee Hills, Hyderabad from 2006, and was also Consultant Neurologist at Apollo Hospital, Secunderabad. He is an expert brain, spine, and endovascular neurosurgeon with special interest in acute stroke intervention, endovascular treatment of brain aneurysms, carotid stenting, minimally invasive brain and spine surgeries, and is also credited with authoring multiple research studies and chapters in books on neurosurgery. He is a member of various medical organizations such as the Indian Society of Cerebrovascular Surgery and the Royal College of Surgeons of Edinburgh. And he has a total work experience of over 22 years. Welcome, Dr. Rajesh Reddy. It's wonderful to have you here at our FB Live series on stroke awareness. And I request you to talk to us about ischemic stroke, acute ischemic stroke, and what it is, how we can recognize it, and what are the treatment options. Over to you.
Hello, everyone. Thank you very much for that kind introduction. Stroke is nothing but a sudden onset neurological emergency wherein it is caused by some kind of a disturbance to the blood flow of the brain, because of which brain goes into a state of dysfunction. And the word here, which is very important, is a sudden onset, because it happens generally without any warning symptoms. And if symptoms happen, the most common symptoms to recognize are the sudden onset speech loss or difficulty in speaking, or a weakness of one half of the body, maybe one limb or one half of the body totally, or it may be difficulty in balancing oneself. And apart from that, there can be a sudden onset unconsciousness, following which the patient continues to remain in a state of unconsciousness for more than a few minutes in time. Anything to do with blood circulation of the brain can be because of a blockage of the blood supply, which is called, because of which there may be a lack of oxygen delivery to the cells, resulting in a type of stroke called ischemic stroke. The other type of stroke is called as a hemorrhagic stroke, wherein the blood moves out of the normal circulating pathways because of the rupture of a pathway along which it is traveling. So that is called a hemorrhagic stroke. Most common stroke is ischemic. About say 75 to 80% of them are ischemic strokes. The remaining 20 to 25% are hemorrhagic strokes. And in both the cases, the symptoms are more or less the same, except that in hemorrhagic stroke, you may have a sudden onset headache, and there can be fits or seizures in addition to the earlier discussed symptoms. Now, ischemic stroke again can be because of a narrowing in the blood vessel, which may happen either in the neck, or it can happen after the blood goes into the head, and it can be because of a narrowing or a sudden onset block in the blood circulation. The reason for this block could be either, usually it's a blood clot, which is traveling along the pathway of the blood or the blood circulation. This clot can arise most commonly from the neck because of constant aging, or because of accumulation of some fat, or the blood cells itself, which we call as a thrombus. So the most common type of block usually arises because of dislodgement of a part of a clot from the neck, and then they travel into the brain and block a particular blood vessel. The other cause could be because of migration from any other part of the body, usually the heart, the pumping mechanism, especially in people who have got artificial valves and who are on blood thinners already, because of some kind of accumulation of cells or thrombi over the valves. They can get dislodged and then they can enter the brain, which is called the embolic type of stroke. The first one is the thrombotic one. Apart from this, the other sources can be because of some kind of a balance in the factors which are responsible for maintaining the blood in a thinned out state. We call it the coagulation factors or the anticoagulation factors. When there's an imbalance between both of them because of some congenital abnormality or because of some acquired reasons, that is the other reason for an ischemic stroke. Ischemic stroke, most of them are minor strokes, in the sense that they tend to block only a small blood vessel, or which can supply a part of the brain. So around 80% of them are minor strokes. So if they are properly identified in time and then treated in time, they'll have a very good recovery. The remaining 20% of strokes are called the large vessel occlusions. Large vessel occlusions means a blockage of any blood vessel which is 3 millimeter or more in diameter. So these strokes can be catastrophic, and in spite of the best treatment, can have some long-standing neurological disabilities or deficits. However, with the recent advances since 2015, there are so many other new options to treat these patients if identified in the correct period of time. So apart from the recognition of symptoms, it is also important that the patients are transferred to the right center so that there is no wastage of time, and their appropriate investigation needs to be done, and the appropriate treatment, either medical or in some cases we call it the interventional techniques, patients are likely to have good outcomes.
So you were saying that the patient has to come at the right time. So once the stroke is recognized through the fast or whatever, like the common symptoms that can happen, what is the time that we call as the golden hour where they need to come? And you were saying that they need to come to the right facility. So could you tell us a little more about what would be the best facility for acute ischemic stroke to be treated, doctor?
So when we say the nearest hospital or in the golden period starts immediately as soon as the symptoms start, and usually in the first 3 hours is the golden period, and then even beyond 3 hours, the recent studies have shown that in some people to 4.5 hours medical treatment can be initiated from the time of onset of stroke. And with the newer techniques of removing the clot physically from the brain by interventional techniques, we can go up to 6 hours. And more recently, we have found that even in selected subgroup of patients, these procedures can be done up to 24 hours, provided we have both an imaging confirmation that there is still a part of the brain which can be salvaged despite of lack of oxygen during the initial 24 hours. When I say a stroke, the nearest hospital or a stroke ready center, there are two types of center. One is a stroke ready center, and second thing is a tertiary care center. Stroke ready centers are where you have an experienced team of emergency people to identify the stroke. Then we have an imaging modality to diagnose whether it's an ischemic stroke or an hemorrhagic stroke, and a neurologist who is there available to decide whether the clot busting drugs or thrombolytics can be administered in these patients to dissolve the clot. When I mean a tertiary care center, it means the availability of a cath lab facility or a facility where you can take up the patient for interventional procedures, same way as we do for the heart or a heart attack, where we do percutaneous interventions or the coronary stenting. Similarly, for the brain, we can go into the brain through a 3 millimeter hole in the thigh, and we can go and physically remove the block in the major vessels wherever and whenever it is indicated. So the nearest hospital need not always be a tertiary care setup. It is a place where a patient's symptoms can be identified, the diagnosis can be established, and if necessary, the early medical therapy can be initiated so that at least the initial stage of treatment is initiated before the patient is being transferred to a higher center in case he has got a large vessel occlusion where mechanical thrombectomy or intervention procedures need to be performed.
So could you now tell us about the treatments? So we were talking about the medical treatments and then the interventional treatments. So what are the medical treatments for somebody coming with all the symptoms of an acute ischemic stroke and after they are investigated?
So like I discussed earlier, the ischemic stroke can be thrombotic or embolic in nature. If it is an embolic stroke, then it is going to be a small vessel in the brain which is probably blocked. And if you don't find a source, clear-cut source, sometimes in 30% of them, whatever investigation you do, you may not be able to find out the exact source because it is a tiny clot of a millimeter or two which has arisen somewhere in the body and gone and blocked the particular vessel in the brain. In such cases, we treat them with blood thinners, so the antiplatelets, what we call, dual antiplatelets for the initial, say, a month or 3 months, depending upon the risk factors. The risk factors being most important risk factor being diabetes, and secondly, hypertension and smoking, apart from the usual abnormalities in the cholesterol levels in the body. So these are modifiable risk factors, which means that if you control these factors, probably a risk of stroke is likely to come down. So medical treatment in the form of blood thinners is for the embolic stroke. On the other hand, if you have a thrombotic stroke or where there is a source in the neck or somewhere in the body which is going and blocking a significant part of the blood vessel, which is causing a significant amount of dysfunction to the body, then we use something called the clot busting drugs. If the patient has arrived in the emergency up to 4.5 hours from the time of onset of stroke symptoms, these medications are given in injectable form, and the patient needs to be monitored in the ICU because there is a 5 to 10% risk of the ischemic stroke turning into a hemorrhagic stroke when these blood clot-lysing drugs are used. So this is a thrombotic stroke where we use ischemic thrombolytics or the clot-busting drugs. In the other setting where 20% of ischemic strokes, which can be large vessel occlusions, as I mentioned earlier, where the blood vessel diameter is more than 3 millimeters, just a clot busting drug may not be enough to completely dissolve the clot. In such cases, the treatment with the clot busting drug or thrombolytics is started, and then the patient is wheeled into the cath lab as early as possible so that the area of block can be physically removed by means of aspiration devices or stent retrievers, what we call as thromboaspiration or thrombectomy. So these are the three modalities of treatment for an acute stroke. For a chronic stroke, which means a patient who is already on blood thinners and who is getting repeated episodes of stroke, who doesn't have any heart issue, which is a source of thrombus or the clot, or if he has got a problem in the neck, we do some procedures called as an open procedure and called an endarterectomy, or a percutaneous interventional procedures called as carotid stenting. So these are called as a prophylactic procedures. Someone who's got a stroke where we have found out a source in the neck that this could repeatedly produce small clots and dislodge it into the brain, then in these cases, we do prophylactically to prevent further strokes in the future. It's an endarterectomy procedure or a stenting procedure.
So what is the prognosis like, after, if it is caught in time, what kind of recovery do these patients make?
The recovery pattern depends upon several factors. First is the initial timing of arrival in the emergency and seeking medical treatment. Like I said, any patient who comes within the first 4.5 hours for medical treatment, or in large vessel occlusions up to 6 to 24 hours, when receiving appropriate treatment, they have got at least a 50% chance of recovery over the next 3 months. There are people who recover early within a few days. At the same time, there are people who might take a longer time. That depends upon the ability of the brain or neurological plasticity, what we call. Younger patients tend to have a better recovery, unlike people who are more than 60 years of age who have got underlying medical problems. Second thing is the amount of deficit they had at the time of presentation. Someone who's got a minor weakness or a minor imbalance or something, who are fully conscious at the time of arrival, they tend to do well. Unlike people who are in a comatose state or who have already got some kind of a swallowing dysfunction or a breathing dysfunction because of the weakness of the nerves which control the swallowing and the breathing part, or who have got a dense weakness and are progressively going into a comatose stage within a few hours time from the time of arrival, they tend to do a little bit on the on the negative side. However, with the available facilities, they can still be subjected to a neuro rehabilitation module, where intense physiotherapy is given after the initial medical treatment or intervention. And with intense physiotherapy, they have a fair scope of survival as well. They might be dependent on others for the activities of daily living, but however, they may recover over a period of anywhere from 3 months to 6 months with intense physiotherapy.
So you were talking about the stroke rehabilitation program. So could you give us a little brief overview on what it exactly involves?
So like I discussed, what happens after a stroke is patient can is usually bedded in a large vessel occlusion. Let's talk about the large vessel occlusions, because minor strokes anyway are going to improve over a period of time with minimal amount of assistance. So the large vessel occlusions, where person is semi-comatose, in the sense they are not able to breathe properly on their own, they need some kind of an assistance. Similarly, they may not be able to feed on their own, so they require some kind of a feeding tube, which is placed either through the nose or directly into the stomach, called as a percutaneous endoscopic gastrostomy tube. The other thing is because of the paralyzed limb is going to be remaining in a particular attitude, it is going to become stiff over a period of time. The physiotherapy is aimed at reducing promoting movements in the appropriate joints so that they don't become stiff. Because once stiffness sets in, even if there is going to be recovery in their power, they will not be able to move that particular limb. So the aim of physiotherapy is to prevent stiffness from developing in the paralyzed limbs. Apart from physiotherapy, the nursing care is important, because they are the ones who are going to take care of the nutrition part, which is also equally important in terms of recovery. So the nutrition may be through the nasogastric tube or through the stomach directly. And third thing is the prevention of other complications like pressure sores, because a change of posture on the bed is very important to prevent pressure sores. Similarly, chest physiotherapy is equally important to bring out the secretions so that they don't develop any chest infections. Similarly, care of the bladder and bowel, because frequent change of catheter when appropriately required in 3 to 6 weeks time, depending on what catheter has been placed. This will take care of preventing urinary tract infections. So all these are also important part of the rehab program. Apart from this, for patients who are cooperative enough, we have something called as robotic rehabilitation, wherein the haptile feedbacks are taken by the robo, and it initiates a particular type of movement or assists patients in physiotherapy. And especially in the other thing which we take care of in physiotherapy is the balancing part, because someone who has got a stroke in the back of the head, these are the areas where we have the balancing organs, where the power may be normal, but they may not be able to balance themselves while walking. So training of, that's called the gait training. So in a nutshell, it starts from the feeding part to care of the airway, we call it, and the prevention of bed sores, maintaining the tone or appropriate position of the body, prevention, frequent change of posture, and balancing. And apart from that, there is also a part called the cognitive rehab in patients who have got memory and speech disturbances. Training in speech and memory with some simple techniques is also a part of the rehabilitation program.
Are there any gold standards for stroke treatment, as in we have a standard of care or a stroke treatment protocol or a clinical guideline?
A stroke-ready hospital, let's say a tertiary care center for stroke management, should have a good emergency team, because they are the ones who will receive the patient, who will be identifying the symptoms and conveying it to the neurologist on call, and then comes the radiology department, the neuroradiology setup, where we need to have both the CT scan and the MRI with technicians who can perform special imaging techniques during odd hours, because most strokes tend to be wheeled in during the odd hours at the night time, and these services should be available. And apart from the emergency, the radiology and neurology services should also have a neurosurgery team, a neurointervention team, an appropriate neurocritical care setup, because it has been found that patients who are treated in a proper neurocritical care setup, they tend to have better outcomes compared to people who are placed in a general ICU, because the training of the nursing staff is different in a neurocritical care setup compared to what it happens in a general ICU setup. And like I said, it doesn't end with the medical treatment. It needs to be followed upon with the neuro rehabilitation team. The nutritionist is also an equal important part of the rehabilitation training. So a proper stroke setup should include all these domains, starting from the emergency team up to the rehabilitation setup for a good recovery.
You spoke about most of the interventions and what is latest in the treatment of stroke. Is there anything more that you would like to add in terms of something that is really a very innovative or a very advanced method which has come to treat stroke?
Yeah, so these interventions in stroke were actually, they came into fame since 2015. Because prior to that, it was only in the trial phase and they were only in the medical treatment phase. So these interventions, like I said, are meant for large vessel occlusions. And since 2018 onwards, we have found that the time frame from 6 hours has been extended to 24 hours for treatment of acute ischemic stroke in selected people. The way we decide this is by doing an imaging. So advances in radiology have given us this extended time window in selected group of patients. What we study here is how much of tissue is already damaged and how much of tissues can be retrieved. So that is called the core and the penumbra. The core is the area which has already been destroyed, and the penumbra is the area which can be saved potentially if you can reperfuse or establish blood flow to that area. So with an imaging techniques, either by a CT or an MR perfusion studies, we can determine this particular amount of brain tissue which can be saved. Now we have got softwares which can automatically calculate these, instead of sitting and manually checking how much of volume is there, we have softwares called the rapid software, which can be installed into these scanners, so that once the scan is done, the radiologist or the neurologist do not have to go and physically see the scan themselves. They get an automated message on the app, which can help plan the further intervention treatments in appropriate people. So this is it's
that they need to remember.
See, apart from identifying the symptoms of stroke, I would say prevention is also equally important. Prevention includes some modifiable risk factors. Some of them cannot be modified. Like I discussed earlier, the modifiable risk factors include control of hypertension, diabetes, quitting smoking, consuming alcohol and within the limits, and physical activity is also an important part of this treatment. The non-modifiable risk factors, of course, are the age, and if there's a family history of stroke, someone is again prone to stroke. So those things cannot be modified. So targeting the non-modifiable risk factors will help us, because these are all non-communicable diseases, and these are likely to grow in the future, unlike the communicable diseases, because the aging population is increasing day by day over a period of time. So I would say prevention is also equally important. And apart from prevention, after following preventive measures, if someone is going to develop a stroke, then reaching the correct hospital at the correct time is also equally important. And like I discussed, how do you identify a correct setup? Because it is not only the treatment which is important, the follow-up care in the terms of rehabilitation also determines the outcomes in cases of stroke. So prevention, going to the appropriate setup for the treatment, and following the rehabilitation protocols are equally important in stroke recovery.
Dr. Rajesh Reddy, thank you so much for participating in our discussion today. And dear viewers, I do hope that had a good enlightened discussion about acute ischemic stroke, and more importantly, how to prevent it and how to ensure that if there is an acute ischemic stroke, prompt treatment to the right place is very, very important. Please do continue to follow us on our YouTube channel for the latest healthcare updates and information. And on the Facebook page itself, if you have any more questions or queries, you know that you can always reach us on the comments or you can post us a message. Till we meet again next, stay safe, stay well, be healthy. Thank you and namaste.